Okay, folks, today I want to talk a few minutes about neuropathic pain. And many patients come with this problem, and there are certain descriptions they use, like burning, shooting, pins and needles. It feels like electricity. These are the descriptions they use to describe neuropathic pain. And it is important that we know how to treat neuropathic pain. So look for these descriptions. It feels like pins and needles. It feels like burning sensation. It's a sharp pain. It feels like electricity passing through my fingers. Like those are the characteristic terms used when patients describe neuropathic pain. I want to take a few minutes this evening to describe the main medications we use to treat neuropathic pain. So, neuropathic pain, many people use opioids, but non-opioids, we need to think about TCS. So, among the TCS, what do you use? So, on one side we have opioid medications, on the other side we have non-opioid medications. The first one is tricyclic antidepressants. They are the very good first-line treatment. Desipramine, nortriptyline are very important. They cause less orthostatic hypertension, and they also have fewer anticholinergic effects compared to amitriptyline. You start with like 25 milligrams and you go up. Then we have calcium channel alpha to beta ligands. So these are like you heard about gabapentin or pregabalin. So gabapentin and pregabalin, they are very useful. Now they are most commonly used medications. They cause sedation, ataxia, dizziness, but they give very good relief to the patients who take them regularly. So gabapentin, you start at a low dose like 100 to 300 milligrams a day, and you titrate upwards, and there are patients who take as much as like 3600 milligrams a day. So gabapentin is that. Then there is a pregabalin. You start like 150 milligrams in divided doses. So both can cause accidental overdose. And when there is a history of heart failure, when there is a history of arrhythmias, you need to be careful. So gabapentin can also add it to some opioids to give more relief from the pain. Then there are selective serotonin norepinephrine reuptake inhibitors, SSNRIs, like duloxetine and venlafaxine. They are also first-line treatments for neuropathic pain. Patients should be advised to take duloxetine on a full stomach because it can cause nausea. Duloxetine should not be combined with other serotonin or norepinephrine uptake inhibitors, but it can be combined with gabapentin or pregabalin. And also, venlafaxine can cause hypertension and it can induce ECG changes. So in patients with cardiovascular risk factors, you need to use venlafaxine carefully. So that's an important point I want to emphasize. Venlafaxine can cause hypertension and can induce ECG changes. So patients with cardiovascular risk factors should be carefully monitored when you're starting them on this medication, this venlafaxine FXR. The other medication is tramadol, and you can also use 5% lidocaine in post-herpetic neuralgia. So different medications you can think of when you're dealing with these patients. So neuropathic pain, and even there are over-the-counter medications like capsaicin, tapentadol. These are basically oral mu receptor reuptake inhibitors. And there is carbamazepine we use in trigeminal neuralgia. Then you can also use botulinum toxin. So you see how many different medications are available to treat neuropathic pain. So it's not just opioids. Many times we give ibuprofen and Tylenol, and when the patients, if they're not working, we simply go to opioids. But you don't have to do that. There are many medications based on the presenting complaints. For example, patients with metastatic bone pain, you can cause bisphosphonates. They help in some patients. And you can also think about nerve blocks. Like, for example, a patient coming with a pancreatic cancer, you can give like a celiac plexus block, and also facial nerve blocks for people with the facial neuropathic pain, or trigeminal nerve block for people with the trigeminal nerve pain. So the nerve blocks are also useful to treat neuropathic pain. And then we have to think about corticosteroids like dexamethasone or prednisone. They can be helpful in patients with a headache due to increased intracranial pressure. They decrease the intracranial pressure, and they also decrease the spinal cord compression. And when there is like a invasion by the tumor into the nerves, these corticosteroids, they put down that compression and give lot of relief to the patient. So you can also use ketamines. So ketamines help with neuropathic pain. So those are the important classes of medications I thought would be very useful. Then of course there are non-pharmacological treatments. Non-pharmacological therapies are also valuable in treating pain, like hot or cold packs, massage, physiotherapy can be helpful for musculoskeletal pain, and similarly biofeedback, acupuncture, chiropractic, meditation and music therapy, cognitive behavioral therapy, guided imagery, cognitive distraction, framing, they are all like non-pharmacological ways to treat neuropathic pain. But when patients come with seeking a medication, then you can think of the different medication groups I gave, like tricyclic antidepressants, then selective serotonin norepinephrine reuptake inhibitors, then we have calcium channel delta ligands like gabapentin and pregabalin. Then we have nerve blocks, then we have tramadol and capsaicin. So all these are different kinds of non-narcotic neuropathic medications. Hopefully you got something, and thank you very much.